Good morning, my name is Sarah McPhillips from the Huntington's Disease Association Northern Ireland, and we're going to hand over now to Jude Munn, who's a specialist dietitian, and she currently works with the Neuropsychiatry Department at the Barbary for Birmingham and Sullivan Mental Health Foundation Trust, where she's worked since 2005. And Jude's going to be talking to us today about diets and nutrition in the context of Huntington's disease. Okay, Jude?
Yeah, and I just say thanks very much for asking me to speak. I've worked in the team here since 2005, and so I've thoroughly enjoyed it. It's a very good team, and the patients are very rewarding to work with, and it's often complex, but very rewarding in the same way. I was going to start by doing like a little talk with a few slides, and then we're going to go through some questions afterwards. So hopefully you'll enjoy it, and I'll just share my screen with you. So I'll just upload this. So hopefully you'll be able to see this. And everyone can see it, can they?
Yep, that's great.
Sorry. Okay. So yeah, I've been a dietitian for a long time, but I've actually found working with this client group most rewarding, and it's quite a fundamental role for us within the team, working closely with speech therapy and occupational therapy and the consultant. The main problems, just trying to think how to move the next, sorry. Trying to work out how to do the next slide, sorry. Oh, there we go, sorry. So the two main problems from our point of view is weight loss and swallowing problems. And weight loss can be quite rapid and quite dramatic. So our role really is to help patients to maintain their weight or to gain weight and meet their nutritional needs, to be able for them to cope with the disease as it progresses. And it can definitely help with people, you know, if they can keep their weight and eating better, then they're going to feel much better in themselves. And again, swallowing problems is quite common again, so we'd be looking then at supporting patients to adapt their diet to meet their needs within that. And often energy requirements are high for a lot of patients, and again, having to have different textured diet can make that more problematic. So we'd be looking at supporting patients and carers with that. So there's increased requirements, not in every patient, but in a large majority, and this is due to involuntary movements, and also there's something else metabolically that happens where patients' requirements do increase, and they change throughout the disease progression. So sometimes patients' requirements are low and could just be normal, even less than normal. But the majority, I say, would need probably at least 1,000 calories more than the normal intake, which would be 2.5 for us normally, and then about 3.5, I'd say, for the majority of patients. And again, I think sometimes if some of the patients are rigid, that seems to increase the calorie requirements as well. I think the rigidity in the muscle tone seems to increase calorie requirements, but it's not uncommon for patients to sometimes, we maybe not see them for 6 months and they might have lost, we've got a couple of patients at the moment through COVID who've actually lost about 15 kilos since February, so we're happy to give them a lot of support. Again, there's decreased food intake if it's physically harder to eat and to feed yourself. Again, and if someone's on pure meals or having thickened fluids, again, they may be decreasing their food intake. So, as I've said, there's a wide spectrum of energy requirements in early and middle stages. And again, we just need to be monitoring that as best we can. Again, do increase the movements. Again, some patients, when I was a student, I was told that patients with Huntington's disease needed 5,000 calories. And when I first started working, I didn't see anybody who needed that amount. But I probably have seen 3 or 4, you know, over the time I've been working, where they have needed 5,000 calories. And one of them was a lady who was 42 kilograms. She had an overnight peg feed of 2,000 calories, and then was eating more than her husband, and eating lots of chocolates, and was having about 5,000 calories. So we have got a few patients that are around that amount, but I'd say the majority are about 3.5. Sometimes in later stages, requirements are even higher, and if somebody unfortunately does have a pressure sore or something like that, then requirements can be really high, and they can change quite quickly as well. So again, it's just about trying to monitor that. So our role then is to assess the patient's current diet and weight, and just to see what's normal for them. We obviously want to try and minimise weight loss as best we can. We want to support with a modification of texture of food if they need to have a softer diet or a pureed diet, and then to discuss artificial feeding at an appropriate time, and to try and find out patients' and carers' decisions on whether it would be something that the patient would like or if they would want in the future. So again, and that would be working with the whole team as well. So when we're doing an assessment, we'd look at a current weight and height, and finding out the BMI. Now, the BMI recommendations for patients with Huntington's is higher than normal. It's 23 to 28. It's not 20 to 25, which, like ourselves in the normal population. Again, it's better for our patients to have a higher BMI, because the weight change can be so dramatic, and also that seems to be that the higher the weight, the movements are less and then more steady on their feet, and also their blood sugars are more stable, which can, if someone's got low blood sugars, that can impact on mood. Some people are quite sensitive to blood sugars and can become irritable and maybe more aggressive if their blood sugars are low. So again, trying to maintain a higher BMI is beneficial. We'd look at the weight history of a patient. So we might see a patient in clinic who is 10 stone, for example, or 60 kilograms, and they're within the normal weight range, but in fact, they've actually lost 10 stone. So we need to find out what is normal. We've all got a normal weight that we've been most of our adult life, and that's probably what our bodies really want to be. So we really want to take a check of any weight changes in the history. We take a diet history of what their current diet is. Any identification of swallowing problems, and relevant social details, who's looking for them, who helps them with food provision if they're looking after themselves, and that sort of thing. So the factors affecting food intake. So obviously preparing food with movements and safety and initiation of being able to prepare foods can become more complex, and we'd work more closely with occupational therapists with this. Again, eating can become much more difficult with a lack of hand-to-mouth coordination. Forgetting meals, often patients need to be prompted to eat, and sometimes it's helpful to have a reminder on the phone at meal times, or maybe a call from a family member to just remind them to eat. Food can go cold. If it takes a long time to eat, then food can go cold and it might need reheating. We wouldn't encourage anybody really to be taking longer than half an hour really to eat a meal, because of fatigue. It just becomes quite hard. So it might be looking at different types of food that are quicker and easier to eat. And fatigue seems to be a common problem maybe later on in the day. So it might be to have more at breakfast when the appetites maybe hungry and less fatigued. So it's again, working with patients on an individual basis to check that how we can help with that. Again, obtaining food, planning what to buy, things that we probably take for granted and quite without thinking, but it's, support with planning what to buy, shopping, maybe communicating when they are shopping, housebound, if they're housebound, who's getting the food, and if they're going shopping, they've got a nice supportive somebody at the shop to help them with that, or are aware of them, of how they are. Again, chewing is a coordinated action. So again, some patients, there's this might cram food in their mouth and that they're eating far too rapidly. And then again, that's a choking risk. So I suppose it's encouraging patients to eat more slowly. It might be using a teaspoon instead of a fork or a bigger spoon, so that they have to use more spoons. That would naturally reduce the amount into someone's mouth. And again, teeth and dentures might be loose. If someone's lost a lot of weight, their dentures might be loose, and that maybe needs to be addressed. So, bearing in mind, and again, if the food's not chewed properly, that again can be a greater risk for choking. And then we'd work closely with speech therapy. I know Elaine's speaking later on working with swallowing. We work closely together to support patients on the modification of textures. And again, some patients are fiercely independent and don't want to be fed and may be spilling quite a lot of food, and this may be why they're losing weight. And then if they're happier, sometimes they then make a decision that they're happier to be fed, and then their weight might increase again, or their nutritional intake. So, our role really is to help people maintain their food intake. So providing information on the importance of food. And again, we'd be discouraging dieting. So the advice is quite different to normal healthy eating, because it's tricky to get the number of calories in if you're eating a diet that's maybe too high in fruit and vegetables, which are lower in energy, and encouraging people to have more fats in their diet, which have got more calories in them, and more sugar, whereas maybe in the past they've tried to avoid those because they feel that they're unhealthy. So it's reassuring patients that we're looking at what their individual needs are. So we're encouraging good practice, so encouraging patients to have 3 meals a day and snacks. If it's taken longer to eat, it's maybe better to be having something 6 times a day, 3 meals and snacks, even if it's a milky drink, to try and get those extra calories in. Again, modifying the texture as necessary as guidance by the speech therapy. And again, looking at energy dense food. So for my role, it's really nice to be able to encourage higher energy dense foods. And often patients are happy to eat and they do have a good appetite, which is great. And I've also never used supplements as much as I have in this client group. So these are prescribable supplements. I'm not sure what you get in Northern Ireland, but if you have Nutritia, but we use Fortisips, and so they've got AIM shakes and milkshakes, and there's a whole variety of different supplements available. But I've probably never used supplements as much as I have in this client group. But again, this client group does have higher energy requirements than normal. Again, it might be, we've talked about regular meals and snacks, but we're looking at a nice quiet environment. Sometimes having a distraction like telly, or if there's a lot of people around talking, that can become a problem, and it's more difficult for people if they're having to concentrate on their swallowing. It's maybe better to have a quiet environment, although on the other hand, some patients will only eat in front of a television. So I suppose, again, it's looking at the individual, but if you can have a quiet environment, that can be helpful. And again, meal times can provide an opportunity for positive contact between a carer and a client. We don't really want food to become an issue. We want it to become an enjoyable experience as best we can. And I know some carers get quite anxious when their loved one's not eating. So when we're looking at modifying texture, food and fluids, it would progress to the normal to chopped to mashed to pureed food. And I don't know if you're aware, but there's international descriptors for swallowing called the IDSI. It's like an international descriptor framework. So these will be within these modified textures. And there's quite good meal plans and advice within those textures. So chopped, soft, and is like a level 6, soft and chopped, I think. Mashed and moist is level 5, and then pureed foods is level 4. So we can have more details with that. So when we're talking about energy dense foods, we're talking about adding fat. So If patients will drink whole milk, often patients are on semi-skim milk, we'll push that. And there's also something called breakfast milk, which is the old gold top milk. Encouraging butter, margarine, cream, cheese, fried foods. You know, I know people are probably, maybe some people keep off butter and things that worry about cholesterol. In this client group, raised cholesterol is very, very low. I think I could probably count on 2 hands how many patients I've had that have had to raise cholesterol. So we're not having to worry about the cholesterol side of things. So we would be encouraging, if they like butter, create whatever they like within those foods, and frying foods, adding extra butter to potatoes, that sort of thing. And then again, sugar, cake, sweets and chocolate. I know someone's worried about dental caries, maybe just reassuring people and to say had to have sweet foods with the meal, then it reduces the impact on the teeth with sugar. And milky puddings are good again because they wouldn't have the same problems with the sugar on your teeth, carcinogenic effects. So the supplements that are available, there are some that you add to food. I don't know, you may have heard some of these, Maxidule, Polycal, which are glucose polymers, and they're tasteless powders. So 1 teaspoon is about 20 calories. So if you add 2 teaspoons to 10 things, that's 400 calories. So it's a way if someone's eating a good volume of food and it's hard to get any more quantity in, then that's quite a good way of doing it. They're on prescription. Now, some patients may not be happy with this, and if they're feeling a bit paranoid, they might not be wanting to have things add to their food. So again, that would be, you know, down to an individual whether that's suitable or not, but it's quite an easy way of getting extra calories in without changing volume. And then food and fluid supplements, there's AIMS, Scandal Shapes, they're milkshakes. I don't know if you've got AIMS in Northern Ireland, but they're really quite big now in the UK, and the cheapest supplements are 49 pence compared to some of the others. And then the Scandal Shake, which are higher calorie supplements, they're 600 per milkshake, which is great in 200 mils, but they're quite expensive, and here the GPs would rather us be using AIMS. And then there's Fortisips, which are quite, and Ensure, which are all quite standard feeds from different companies. They're about 300 calories and they're nutritionally complete. Then there's something called collagen shots, which patients can have like medicine after their meals to top them up, and that can then be, if you have that 3 or 4 times, about 500 calories without again having to have too much volume. And then there's some pudding ones called 40 Creme and Nutri-Creme that patients often like, especially if they're on modified texture, because they're like a pudding, and some of them have like fibre in them and extra calories, so they're quite good as well. Some patients can get really hooked onto the supplements and may end up having 5 a day. And again, I think it's going with the individual patient with what they want, and trying not to be worried about variety. Some patients will only want one thing and a few things, and might not want the variety that we'd rather them have. So we had one patient who stopped eating at one point, and then she just started, she just wanted white arrow mousses and was having 20 a day. So I think we had to support her with that, and just be bearing in mind that that's still calories. It's got some calcium in it. There's no good or bad foods. All foods have goodness in them, and often it's just a phase, and then it'll move on to something else. And I suppose it's just working with the individual with that, and reassuring them. So in summary, supplements then we only use when we can't maintain nutritional status with food. You'll definitely need supplements on a pureed diet. It's very hard to get enough calories in with on a pureed diet, because the diet's diluted with gravy or water, or ideally with milk if a patient likes milk and cream. And again, if in palliative care, you'd be using supplements. And just we need to be mindful of taste fatigue. If someone might be on a supplement for a while, or they might get fed up, we need to be looking at alternatives. And again, this swapping from one food to the other is quite common. So other factors that can affect food intake, so constipation can be a problem. Again, if someone's not eating well, they can become constipated. If they're not drinking enough, they can become, and again, if they're on a pure diet, they may be having less fibre. Some medications, some antipsychotic drugs are side effects of constipation. So really to try and support patients as best to increase their fluids and be maybe, you know, if they are spilling fluid, be mindful of how much they are having, or looking at other ways of having fluid with, you know, more foods that have more fluid in them, like yogurts and you know, soup-based things, or some of the pureed meals. Increase fibre where we can. So as long as they're able to have things with food with pips in, like kiwis, tomatoes, as long as they're okay on the diet, the modified texture diet, are helpful, and prune juice even. Again, with fibre, don't increase it too quickly because it can upset the stomach, so increase it gradually. Weetabix, a lot of patients do like Weetabix, and that's obviously a great source of fibre. Then there are prescribed laxatives as well, and there's a fibre supplement called Optifibre, which is available on prescription. I think you could probably get it on over the counter as well, which is like a powder you just add to drinks, which is quite good. And again, probiotics are good as well. The probiotic yogurts like Yakult or Actimel, or the supermarket own brands, are quite good for constipation too. So vomiting and reflux again is another factor that can be a problem, and again in about 10% of patients, again just supporting the patient separating food and drink, and encouraging patients to rest after their meal and maybe sit up at a table and clean and replace the meal. Often they're happy to have the meal replaced. And then when we look at artificial feeding, there's 3 types of feeding: nasogastric tube, nasoduodenal tube, or PEG. Nasogastric tubes, sometimes these are used but can be pulled out more easily, and PEGs are often more often used. PEG stands for percutaneous endoscopic gastrostomy, so it's a tube into the stomach. And you know, again, we support the patients with advice and support around this, and their carers. So the pros are to maintain and improve nutritional status, weight may increase, and it can obviously improve fluid intake and stop dehydration and less UTIs. But there's still a reduced risk of aspiration, because you can still aspirate on saliva, so it doesn't remove it. And there's a big question mark about whether it does prolong life long term. The disadvantages or the cons are: it's a surgical procedure, the risk of aspiration is still present. Food may be one of the last pleasures, again that reduces contact with care and the patient, and it has to be used. So the decision needs to be, you know, well thought out with patients. I think for some patients, if they are struggling to meet their needs, it's quite good as a top-up. But again, it needs to be considered carefully. And again, we need to consider that patients can refuse food, but it's very difficult to refuse a feed. And there have been cases where patients are pushing people away when they're being fed, and that can be really distressing. So we need to be mindful if patients are having tubes, when they would want to have the tube removed, and working together really with the team and the family. So the main things really then to think about are calories, making sure patients have enough calories, is it the right texture, and taste as well. So making sure that food meets everyone's needs and they're enjoying it. And I just want to show an example of a patient of ours who did have a PEG, and then she used to have chopped strawberries and Baileys in the evening as a nice little taster. So that's me for the slides. So I'll just stop sharing this. I think we've got a few questions now. Sorry if I've gone over a little bit with that.
You're grand. We just have about 5 minutes, so I'm going to run over a couple of questions that we've received, Jude, and then there are a number of other questions, but we're going to include those in the follow-up to participants, if that's okay. All right.
Yeah.
Okay, so how soon after you're diagnosed with Huntington's disease should you change your diet?
Well, I suppose that anybody on diagnosis would probably want to make sure that their diet is as balanced as it can be, and they're meeting their needs. Would probably encouraged to be eating regularly, and to be trying to have, you know, maybe 5 portions of fruit and veg, and maybe eating oily fish if they like it. I think we would only really worry about changing it from an energy point of view if they were starting to lose weight or they were losing weight rapidly. So it's really just keeping an eye on the weight, really. So they wouldn't have to make any specific changes on diagnosis, but just maybe trying to have as well balanced and healthy diet as possible and varied.
Okay. We talked a good bit about weight loss. We have somebody who's messaged in about their dad who has a lot of weight gain. And is this something that they should be concerned about, because the dad is quite sedentary, eats a lot of chocolate and fizzy drinks, so high sugar, high calorie foods, and has gained a lot of weight? Is that a concern, or should just continue to let them at it?
I think I wouldn't be concerned, because again, weight can change so rapidly. I wouldn't want anybody to go on a weight reducing diet. If it's bothering them, then it would be to support with them. It might be about maybe going for lower calorie pops, like lemonade is lower than Coke, for example. It's like a 2/3 less, or encouraging diet drinks. And it may be to offer some sort of chocolates or every day, so that maybe if the patient knows they're going to have what they want. I think sometimes if it becomes a bit of a battleground, then it's not, it's not what you don't really want to get into that really with them. So I suppose you have to reassure them without it being a problem that the weight becomes a problem. Maybe just try and look at alternatives if possible. But yeah, work with the patient and try not to worry too much about it.
Some sort of compromise there. Let them continue to eat their sugary, fatty foods, but maybe look at lower calorie intake on if it's going to be problematic. There's a lot of talk of superfoods these days. Is there anything that's considered a superfood for HD?
I know blueberries have been mentioned, and coconut oil. And I know both these foods, the blueberries are high in oxygen, which is good for brain health. They're good for all of us, but they have specifically been linked to some research with Huntington's in rats as well. And the coconut oil, again, is it's got MCT, or it says a medium chain triglycerides. It's a type of fat which can increase ketosis. And again, there's some research now to show that in ketosis and fats are very good for the brain. And there's been some research in rats again with the Huntington gene that has been beneficial to the brain health. So I know that one of the questions we talk about coconut oil on the teeth, but I was thinking maybe it might not taste that nice. It might be better to have it in, use it in cooking. It is a saturated fat, so if somebody to have raised cholesterol, you probably wouldn't want them to be having a lot of it. But as I said, that's very rare. But it's quite. Don't try not to increase it too quickly, because MCT fat can upset your tummy a bit if you had it in large quantities. But it's you could use it in cooking. Is another way of getting it.
Okay. What amount of supplements should a person take with Huntington's disease?
Well, it depends. I mean, vitamin and mineral supplements, do you think it means? Sorry.
Well, I think in this case they're talking about vitamins and minerals, really, because there's another question which asks, how do you know what supplements to take if the person shows no signs of any deficiencies?
Okay. I mean, the current recommendations, probably for all of us, is at the moment is vitamin D supplements. We all should be taking 10 milligrams of vitamin D a day, and the link is with COVID as well. Is vitamin D deficiency seems to be a risk factor, especially as we're now going into winter. If someone's eating a varied diet, I wouldn't recommend any vitamin and mineral supplements. If their appetite's poor and they're not eating very well, it might be worth taking like intakes really, really restricted, and eating a few foods and not eating any fruit and veg. I'd recommend that. If someone's eating well, no, they wouldn't need it. And if you're eating breakfast cereals, they're often fortified with, especially the Kellogg's or Weetabix or a lot of the supermarket owned brands. So they've got vitamins and minerals, so they're a great source of fibre as well. So really, it's just vitamin D, I would say, for all of us and
great.
our patients.
We've come to the end of our time now, so as I said, I'll be following up with all participants with the questions and answers that have been provided, a link to the video and some additional resources. So it just leaves me now to thank Jude for her time and to thank the rest of you for taking an interest.
That's lovely. Thanks ever so much.
Thank you. Bye-bye.
Bye.